Good evening, friends. Very warm welcome to this session, which is called as Critical Reviews of Breast Cancer, being held in the North Zone. And I'm grateful to AstraZeneca for putting up this very interesting program. The format is that we have 6 presentations based on the abstracts which are presented in the space of breast cancer in the recently held ASCO meeting at Chicago. And there will be 6 presentations on various aspects. And it's a very interesting format, and followed by a panel discussion, which is going to be moderated by Dr. Akhil Kapoor. I thank all the presenters, the panelists, for agreeing to join and making this program a success, and all the participants for energizing this activity. And I do hope and trust that at the end of it, we would have more information, more knowledge, and which could be practice changing, which could be futuristic. Let's hope and hear the our specialists who are going to talk about that. Our first presenter is Dr. Shaina Goel, but I would hand over the proceedings back to Anshika from MICE Ideas and to take the introductory part, introduce the speaker, and get going from there. Thank you so much once again. Over to you, Anshika.
Thank you so much, sir, for such a kind words. Now, to begin with our scientific program, I would like to invite Dr. Sheena Goel, ma'am. She is a senior consultant in the Department of Medical Oncology at MEX Super Specialty Hospital, Dwarka, Delhi, and she is going to speak on Serena 6 primary results. Over to you, ma'am.
Thank you. A very good evening. Thank you to the organizing team for the kind invitation. So I'll share my slides. Please let me know if if it is clear or not. Okay, just.
Now we can't see your screen.
So yeah, just one second. Now is it visible?
Yes, visible now. Yeah.
Thank you. So I will be talking about this Serena 6 study. This was presented as a plenary session at the this year's ASCO 2025. This is an interesting study. Here they have used camizestrant, one of the oral SERDs, with a CDK4/6 inhibitor for the treatment of emergent ESR1 mutations during first-line endocrine-based therapy ahead of disease progression in patients with HR-positive, HER2-negative advanced breast cancer. This is a phase 3 double-blind circulating tumor DNA guided study. So in this study design, this was done at various centers. They had taken patients who had been diagnosed with hormone positive, HER2 negative advanced breast cancer, and as we know, started on the standard first line therapy with aromatase inhibitors and one of the 3 CDK4/6 inhibitors, palbociclib, ribociclib, or abemaciclib as the initial therapy, and have received this therapy for a duration of at least 6 months. These patients, almost 3,300 patients, were screened, and during the surveillance, while on treatment, they underwent circulating tumor DNA test with the Garden 360 assay, and they detected the ESR1 mutation in the ctDNA. So the patients who had ESR1 mutation, they were then included in this study and randomized to the 2 arms. So out of the 3,300 which was screened, around 550 had positive, and among these, 315 patients were then randomized. The important criteria was the presence of mutation, and there was no evidence of disease progression on the scans. The randomization was between use of switching AI to camizestrant at the dose of 75 mg once daily and continuing the same CDK4/6 inhibitor plus a placebo for AI, versus continuing the same AI plus CDK4/6 inhibitor plus placebo for camizestrant. The primary endpoint was progression-free survival by investigator assessment, and secondary endpoints were PFS2, OAS, patient-reported outcomes, and safety. They had also stratified the patients between the presence and absence of visceral mets, whether the ESR mutation was detected at the first or a subsequent test, and the time from initiation of the treatment, of whether less than 18 or more than 18 months, and the type of CDK4/6 inhibitor. So, coming to the results, we can see that the switch to camizestrant arm patients did better with a median progression of free survival of 16 months versus 9.2 months and an adjusted hazard ratio of 0.44, which was statistically significant. The Kaplan-Meier curves can be seen to be separating. And the 24 months that we can see from here was 30% patients alive in the camizestrant arm without disease progression versus 5.4 in the AI arm. Looking at the progression-free survival by subgroup analysis, again, almost all the subgroups, irrespective of the disease site, the time of initiation, the type of CDK4/6 inhibitor, or the type of ESR1 mutation, they all favored the camizestrant switch arm. Another important aspect when we talk about metastatic disease is we want to look at the quality of life of the patient. So they did take it into consideration this using the AORTC quality of life questionnaire C30. They found that there was longer time to deterioration in the global health status or quality of life, which was 23 months versus 6.4 months with AI. Again, this was found to be statistically significant. Next comes the PFS2. So in these patients, many of them, after the use of AI or these oral SERDs, they do go on chemotherapy. So the different regimens that they have used in second line, we do have those details. These included chemotherapy. Some of them went to oral SERDs. So when they looked at PFS2, though this was an interim analysis and the data is still immature, but they found that the PFS2 events was lesser for the patients who were on the camizestrant arm. Coming to the safety summary, the adverse event grade 3 or more was 60% versus 46% in the AI arm. The adverse events leading to discontinuation was 1 to 2%, almost same in both the arms. If we come to what was the most common adverse event, so as expected with the safety profile of CDK4/6 inhibitor, it was neutropenia in both the arms, slightly more with the camizestrant arm. Other were anemia, leukopenia. So what we know was a side effect due to the camizestrant was photopsia. But these are brief flashes of light in the peripheral vision. But it was found that this did not impact the daily activities. These patients who had this side effect were evaluated with an ophthalmologist also. There were no structural changes in the eye, no changes in the visual acuity, and it was reversible. These were typically lasting for less than a minute and less than 3 days a week. So they did not have or a very minimal impact on the daily activities. But I feel it would be important to counsel the patient before about this side effect. So coming to the conclusion, our traditional practice has been changing the line of treatment when there is a progression seen on the scans or a clinical progression. So Serena 6 came up with a new idea where they talked about personalizing treatment and doing a circulating tumor DNA test to look for an emergent resistance which may develop, as we know, to AI, and changing the therapy before the radiological or clinical progression. And they found that switching AI to camizestrant with continuation of the same CDK4 led to improvement in the PFS in patients with HR positive, HER2 negative advanced breast cancer. This was consistent across all CDK4/6 inhibitors and clinically relevant subgroups. Also, there was a delayed time to deterioration in quality of life versus continuing this AI plus CDK4/6 and was well tolerated with treatment discontinuation rates of only 1.3%. So this has been the first global registrational phase 3 study to show the clinical utility of ctDNA monitoring and using it to change the treatment. And this could have the potential of a new treatment strategy in oncology. So key takeaways. So this is the same points. I think my take on it would be these are impressive results. And this could be defining the future personalized, individualized treatment that we've been talking about, where we've been looking for different biomarkers to know which patients to intensify treatment. However, if we talk about today, with this data, I don't think we can take it to the clinical practice today. We would want to look at the long-term overall survival outcomes, especially adding to the cost with the regular blood tests. So whether if we add this at the start, do we really improve the long-term overall survival outcomes for these patients? Though quality of life and other things seems to be well impressive with the camizestrant arm. Thank you.
China, as I said, that there will be some abstracts where the data will be presented on potentially practice changing sort of a scenario. Do you
Yes.
think this would be one, and looking at the very impressive separation of the curves and the quality of life, everything, this has the potential to change practice in the, at least if not short term, but in the intermediate future?
Yes, sir. I think yes, because one, we've always been talking about using the best treatment frontline for our cancer patients because we don't know whether they would be fit for second line, and now we know the SERDs are doing better. And the ESR1 mutation at presentation is less than 5, but it goes up to 40 with time, 40% over the time. So I think yes, sir, this would have a change because. These patients, we are actually stratifying these patients. We are identifying patients early who would progress, and this is showing improved outcomes.
So
Though
the
overall,
idea is not to allow the resistance to build up.
yeah, yeah, yes.
Thank you so much. Anshika, are there any questions in the chat box? I don't see any questions. If there are in between, please do let us know that those
Okay,
questions.
sir. Sure.
Thank you.
Back to you, Anshika.
Thank you so much, ma'am, for such an informative talk. Now, moving ahead with our agenda, we have our next talk on uh, INAVO 120 OS analysis. And for this talk, I would like to invite Dr. Ankur Varshney, sir. He is a medical oncologist at Medanta, the MedCity, Gurugram. Over to you, sir.
Good evening. Thank you, sir, for the opportunity. One, Anshika, you have to share my slides still.
Ankur, your voice is cracking. If you switch off your video, it will be better. You'll get a better voice quality. Uh,
Okay, sir.
yeah,
Is it better now, sir?
much better, much better.
Okay, sir. So now we are discussing after moving from a ESR1 resistant variant. Now we are moving one more class upgrade where we found resistance to the endocrine therapy, and this is PIK3CA mutated cancers. So we are studying a phase 3 data which suggests with overall survival analysis of inavolisib plus compared with placebo plus palbociclib plus fulvestrant in patients with PIK3CA mutated hormone receptor positive endocrine resistance advanced breast cancer. Next slide. So this is a phase 3 data whether in patients with PIK3CA mutated hormone receptor positive HER2 receptor negative and the testing of PIK3CA was done either by blood or on tissue DNA test. These patients who have progressed within 12 months of adjuvant endocrine therapy and have not received any treatment for advanced breast cancers were included in the studies. Prior to the study, this was ensured that they had controlled blood glucose level and controlled diabetes. This is because we know that PIK3CA mutated drugs has a side effect which is known as hyperglycemia. So these patients were randomized to receive inavosilib 9 mg OD plus palbociclib 125 mg OD for day 1 to 21 and fulvestrant in the standard doses 500 milligram day 1 to day 15 followed by every 4 weeks. And the control arm include the placebo plus palbociclib plus and fulvestrant in the same doses. Randomization was done into 1:1 ratio. Stratification was done in the presence of or absence of visceral disease, development of endocrine resistance, either primary or secondary, and reason-wise. The treatment was allowed to continue either there was a progressive disease or there was development of substantial toxicity. The endpoint of this study was PFS, and secondary endpoint included were overall survival, overall response rate, duration of response, clinical benefit rate, and safety analysis. Next slide. So coming to randomization, we randomized 161 patients with inavosilib, and the same in the placebo cohort there was 164 patients who were randomized. And the main reason for study treatment discontinuation was progressive disease. Next slide. So we come to the PFS advantage, and if we see in a PIK3CA mutated patients, when we start the drug upfront, The median PFS recorded in the control arm was 7.3 months, while median PFS in the test arm with inavosilib, it was 17.2 months. So we see more than doubling of PFS. And if we see the Kaplan-Meier curves, this difference is maintained throughout the time period. At the end of 1 year, the PFS benefit was 58% versus 31%. At the end of 2 years, this was 41% versus 16%. Next slide. Coming to the secondary endpoint, like overall survival, then the placebo arm has an overall survival of 27 months, while inavosilib showed a median OS benefit of 34 months. This was found to be statistically significant with the hazard ratio with p-value hazard ratio of 0.67 and p of 0.01. So this is reported after a median follow-up of 34.2 months, and we found that improvement in median OS was recorded for more than 7 months, and this crosses the difference, right?
Ankur, we can't hear.
Coming to the baseline characteristics. So majority of the patients post inavosilib received chemotherapy. However, the patients who were on the palbociclib with fulvestrant have received other PI3C agents. ADCs were allowed, and some of the patients include the were received the TDM1. Next slide. Coming to the overall response rates, the overall response rate with inavosilib was reported to be 62%, while with placebo it was 28%. We see a difference of 34% in overall response rates. And if we see the duration of response, then ivosidenib had a benefit of 19.2 months with prolonged duration of response as compared to the placebo, where it was recorded only 11.1 months. Next slide. So now comes the major data, which is the safety analysis. And if we see, then the serious adverse event reported with the use of inavosilib was reported in 27% of patient population, while in placebo control arm, it was 13%. Major adverse event leading to discontinuation of treatment with ivosidenib was reported in 6.8%. As compared to the placebo, it was only 0.6%. So treatment discontinuation because of the drug of interest was found only 6%. Next slide. Coming to the adverse event, as reported, the most serious adverse event reported in both the cohorts were neutropenia, which was present in approximately 91% of patient population. And the major issue was that approximately 82% patient in that inavosilib group and 80% patient in the placebo control arm had this adverse event and either grade 3 or grade 4 range. So as we see, there is comparable. This adverse event was reported because of the palbociclib used, and this is a known side effect when we use palbociclib treatment. Adverse event with inavosilib, which was specific to it, was reported as stomatitis or mucosal inflammation, which was present in 55% of patients with the drug. And this was grade 3 or 4 adverse event reported in only 5.6% patients. Hyperglycemia was reported in 63% of patient population, and this was grade 3 or 4 only 6.8% of patient population. Diarrhea was reported in 52% of patient population, and this was reported to be grade 3 or 4 adverse diarrhea in only 4% of patient population. Another side effect which was reported was rash, which was reported in 26% of patient population with inavosilib, but this was not found to be grade 3 or 4. There were certain ocular toxicities, other adverse events such as the deranged LFT, vomiting, lymphopenia, and pneumonitis were found comparable in both the cohorts. So on the longer follow-up, we found there were no safety signals found, reported with the use of inavosilib, and all adverse events were quite comparable when we see it to alpesilib, and majority of the adverse events of interest like neutropenia and thrombocytopenia was because of the palbociclib, which was found in both the groups. Next slide. So the limitation of this study was because the only CD46 inhibitor assessed was palbociclib, and they had a point because at the time the initiation of this study was done, then this was the only drug available with them. Only few patients has received adjuvant CD46, were only 1.2%, and the American black patients were quite less, which was only 0.6%. Coming to the subgroup analysis of OS, there is a relative low number of patients in many subgroup, which doesn't result in a widespread data analysis. Next slide. So the key takeaway from this slide is, the very first key takeaway from me is, we should test PI3CA mutation in the upfront setting. And if we test this and we found this mutation, we have a knowledge that this patient will not do good with endocrine therapy only. And to these patients, we may offer the first line treatment with PI3CA inhibitors. And so now we have a drug which is approved in the first line, which has shown an improvement in overall survival as compared to the placebo. And the previously reported improvement in PFS was maintained over a longer duration. The side adverse events of hyperglycemia, stomatitis, mucosal inflammation, and ocular toxicities were having a higher frequency with the test term, but they were quite manageable, and their discontinuation rates because of this were quite low. Next slide. So the article is published in NEJM in the May 2025, and drug is still awaiting the FDA approval. Next. So the primary analysis showed that Inavo 120 showed a significant and meaningful improvement in the PFS with a combination of inavolisib along with CD46 inhibitor and fulvestrant in patient population who are PIK3CA mutated, hormone receptor positive, and have shown endocrine resistance in advanced breast cancers. The PFS has a benefit of 15 months with a hazard ratio of 0.43. There is a meaningful difference in overall response rate, 58% versus 25%. And after a median follow-up of 21.3 months, interim OS data were still showing immaturity, but now the final OS analysis has shown OS benefit of approximately 7 months. So, thank you.
Thank you, Ankur. That was a wonderful presentation and cements the concept of the PIK3 inhibitors, and looks like similar. The toxicities almost look like similar: hyperglycemia, rash, diarrhea, and maybe a little more ocular events out here. But one question: how about the choice of? You did make a comment that at that point in time only Palbo was the approved drug. But would you reckon that if we use a better CDK4/6 inhibitor, the results would improve upon all that we have seen here?
Sir, it could be. I'm not, we are extrapolating it, but
Yeah.
definitely ribociclib has shown a OS benefit where palbociclib has not shown it. So the
Right.
use of this drugs can show a better OS advantage.
Thank you so much. Anshika, any questions in the chat box? Anshika, you're on mute.
Hello.
No
Yes,
question.
sir, there are some questions.
There are questions.
Yes, sir.
So I got it. I got it. There is a question from Ankesh Kumar Jaiswal. What is the patient's burden of? Oh. No. Anshika, I'm finding this is a very basic question which can be addressed
Okay.
during the panel discussion. Cancer
Yes, sir.
burden, breast cancer burden. Are only HER2 studies included in these talks? What is the percentage of HER2 and HER2 negative breast cancer? I think we'll reserve it for the panel discussion. Let's
Okay,
move
sir.
on. Over to you, Anshika.
So, thank you so much, sir, for such a valuable insight. So, as of now, Dr. Devendra Paul is not able to join, so we can proceed with the next talk. And for that, I would like to invite Dr. Prashant Kumar Parida, sir. He is an assistant professor in the Department of Medical Oncology at Acharya Harihar Postgraduate Institute of Cancer, Cuttack, Odisha, and he's going to speak on Destiny Breast 06. Over to you, sir.
Thank you. Good evening, everyone. So this is the Destiny Breast 06 exploratory biomarker analysis for TDXT versus TPC in HER2 low or ultra low hormone receptor positive MBC. So we already know the Destiny Breast 06 data after failure of in at least one or two lines of hormonal agents with CDK4/6 inhibitor in hormone receptor positive HER2 low or ultra low subgroup of patients. So there was a significant PFS benefit, though OS data is not yet mature. So this is the exploratory biomarker analysis. This specified biomarker, they have decided a few biomarkers they have taken, and this yes. So the Destiny Breast 06 study design, patient population hormone receptor positive or to low, ultra low chemotherapy in MBC setting, and prior lines of therapy they have included more than two lines of endocrine therapy plus minus targeted agents, or one line for MBC and progression less than 6 months of starting endocrine therapy plus CDK4/6 inhibitor, or recurrence less than 24 months of starting adjuvant endocrine therapy. So there was a randomization between TDXT standard dose 3 weekly versus TPC treatment for of physician choice, and the HER2 low subgroup includes 713%, HER2 ultra low 153%. The baseline characteristic median age 58 years, and they have taken almost 31% de novo MBC, liver metastasis 67%, visceral metastasis 85%, primary endocrine resistance 31%. So the points to be noted here: liver metastasis, visceral metastasis has been taken in 67 and 85. Those are considered as poor prognostic subgroups. Primary endpoint PFS in HER2 low subgroup. There was significant improvement in TDXDR 13.2 versus 8.1, significant. And secondary endpoint PFS in ITT population, both HER2 low and ultra low. Median PFS improvement in TDXDR 8.1. OS data still not mature. PFS2 will discuss safety and tolerability, and this analysis will be going to discuss the biomarker, exploratory biomarker analysis of Destiny BOC. So the clinical outcomes in biomarker evaluation population versus ITT population, you can see the median PFS in biomarker population, TDXT versus TPC, 13.9 months versus 8.2 months median PFS advantage in comparison to ITT, where similar 13.2 versus 8.1, and the HR 0.63, 0.64 similar, both in biomarker population as well as ITT population. Overall response rate 59 versus 33 and 57 versus 57, 59 versus 33 and 57 versus 31. So overall clinical outcomes, PFS, overall response rates in biomarker evaluation population were almost similar or consistent with the ITT population. So the P3 AKT pathway mutation was observed in almost 45%, 281 of patients in biomarker evaluation population, and there was they were balanced across the treatment groups. And you will see the median PFS in wild type 13.1 versus 8.1, and in mutation 13.2. So almost similar benefit. HR 0.61, 0.65. So TDXT improves PFS versus TPC regardless of this P3 AKT pathway mutation status. Similarly, in ESR1 mutation, which is seen almost 51% of patients, and the wild type versus mutation population, similar TXT versus TPC, 15.2 versus 8.1, and 11.3 versus 7.0. So TXT improves PFS versus TPC regardless of ESR mutation, and in BRCA1 and BRCA2, though the numbers are very small, only 7.7% BRCA mutation patients were seen. A total number of 48 patients. In wild type BRCA, TXT 12.9 versus 8.2 versus TPC. Whereas in mutation subgroup, BRCA mutant subgroup, 21.4 versus 5.3, almost 4 times improvement in PFS. So TDXT improved PFS versus TPC regardless of BRCA mutation status, and a potentially greater benefit was seen in mutation subgroup, though the sample size is very small, but there was a significant improvement in PFS and mutation. BRCA mutant subgroup. Confirmed overall response rate. So confirmed ORR was improved TXT versus TPC regardless of big 3 ESR BRCA mutation status. So PFS2, whether in TDXT or in TPC, you can see the forest plot favors in almost each subgroup of biomarkers, whether it is mutant or wild type. But in BRCA mutant subgroup, you can see the significant improvement, 33.7 versus 11.8. So delay in PFS2 was in favor of TDXT versus TPC, regardless of biomarker status, but a potentially greater benefit was observed in BRCA1, BRCA2 mutation subgroup, though this sample size is very small. So conclusion from this biomarker analysis in Destiny 06, TXT improves greater PFS compared to TPC, regardless of baseline big 3 AKD pathway, ESR BRCA mutation status, and overall response rate PFS to also favored TXT over TPC regardless of baseline mutation status, and there was a potentially greater efficacy benefit in TXT versus in TXT in BRCA mutant subgroup compared to all other subgroups, though sample size is very small. So findings in this biomarker evaluation population were consistent with those in the ITT population and provide evidence that TDXT is an effective treatment across patients with hormone receptor positive or MBC after more than one or more endocrine-based therapy, regardless of PAKT, ESR, BRCA mutation status. Thank you.
Thank you, Dr. Prasant. That was a very interesting presentation and a great piece of data that we are a lot of times lost in the clinic, that beyond a couple of lines of endocrine therapy and CDK4/6 inhibitors, and especially where there are other mutations, ESR1, PIK3, or HER2, we don't know which way to proceed. And this data overrides almost everything in HER low, ultra low. I think would you call it a potentially practice changing?
Sir, the TXD definitely is a promising drug because it has been already approved in frontline vaccine 09 and versus TDM1. It has been compared in second line also in HER2 positive subgroup. But we have seen the benefit, especially in frontline. So I'm very surprised that the advantage PFS is almost 15 months in 09. So this is especially hormone receptor positive or to low, ultra low subgroup. This is a group where there is an unmet need, because after failure of CDK4/6 plus endocrine therapy, at least over 2 lines of therapy, we have those several options like exemestane, everolimus. So several biomarkers like ESR1, elacestrant, apihosertib, alpelisib. So these are the drugs were available, but this TDXT. In all comers of HER2 low and ultra low, definitely it's a new addition to the treatment armamentarium of hormone receptor positive HER2 negative subgroup patients.
Thank you so much. And I think we can make a comment about the two questions which were popped up in the previous chat. The burden of disease in India, breast cancer is number one amongst women. And number two, the question about are these HER2 directed, are these abstracts on HER2 positive disease? By now, you would have seen that all three were in HER2 negative patients, actually. So that's the precise answer. Over to you, Anshika.
Thank you so much, sir, for such an important update. So, Dr. Devendra Paul has joined us. So, I would like to invite Dr. Devendra Paul. He's a principal consultant in the Department of Medical Oncology at Fortis Hospital, Ludhiana, and he's going to speak on Amber 3. Over to you, sir.
Yeah, thank you so much. Good evening. Thank you, sir. Can somebody upload the slides, please?
Yes, sir. Arundhati will be sharing your slides.
So I'll be presenting the abstract regarding the Amber T study, study which has now shown the role of a new oral SERD molecule, which is the immunostrand. And this molecule is principally more effective in the ESR1 mutations, and it is an oral molecule as compared to other companion drugs like which are parenteral drugs. So I'll be presenting very fastly the, as I told you, the patient-related outcomes in patients with PR positive, HER2 negative advanced cancer treated with immunostent and versus investigator's choice standard endocrine therapy or immunostent plus abemaciclib, the results from the phase 3 Amber trial. Next slide. So this was the phase 3 trial. You can see the study design. The patients were taken in the metastatic setting or the advanced, locally advanced setting, and the patient were randomized to 3 arms. In the arm 1 was the single agent imlunestrant, oral molecules, and second group was the standard of care endocrine therapy, principally was fulvestrant or exemestane. And in the third arm, it was a combination of imlunestrant along with abemaciclib. And you can see the primary endpoint of the PFS. They compared the A group with the B group in patients with ESR1 mutations, and they also compared A versus B in all patients and C versus A in all patients. Key secondary endpoints was OS, PFS, and safety. And activity endpoint, which is very important for this trial, was the patient-related outcomes. So next slide. So you can see the PFS in patients with ESR1 mutation. They compared the group arm A with arm B, that is imlunestrant versus the standard of care. You can see the PFS was 5.5 months in the imlunestrant arm versus the 3.8 in the standard of care. When we go to all the patients, all the subgroup of patients, there the benefit rises more. That is the imlunestrant versus amibaciclib, that is arm C, had a median PFS of 9.4 months as compared to 5.5 months in this single agent imlunestrant. So the PFS was improved with this drug as compared to standard of care in patients with ESR mutation. And when we combined with that with the abemaciclib, it had profound efficacious role irrespective of the ESR1 mutation. Next slide. So regarding the safety summary, it was a favorable profile. There was no kind of very important, very high grade of side effects. There was favorable safety side effect, safety profile, and there was no oral SCRD specific safety signals. And however, in the arm in which there was the combination of imlunestrant versus abemaciclib, there was a higher incidence of diarrhea, which we all know it is there with the abemaciclib, but still the safety was consistent with the known abemaciclib profile, and there was a low discontinuation rate even in the arm, that is 6%, relative to the available combination regimens. Next slide. So very important in this trial was that they measure the patient-related outcomes. They have various scales for that. They have the URTC, QL3C 30. We have URTC IL-19. They had a specific patient-related outcome related to diarrhea and also related to the injection site reaction for the injectable drugs. Next slide. The global health status, that is the quality of life in patients treated with this molecule versus standard of care. You can see these health status and the quality of life, they were generally maintained across all the treatment arms, and there was no treatment difference favoring immunostrand. There was slightly difference which is favoring the immunostrand versus the standard of care. Next slide. Again, coming to the time to deterioration of this quality of life index, you can see the time to deterioration was numerically favoring the imlunestrant versus the standard of care. Next slide. Then the next question was the overall quality of life and functional domains on the treatment arm with the imlunestrant versus standard of care. Here also, overall, the quality of life and the functional domains were generally maintained across all the treatment arms. They were slightly favoring the imlunestrant arm. Next slide. And coming to the overall symptom domains, how the patient was feeling. Again, here also, symptom domains was broadly similar across all the treatment groups. Next slide. regarding the difference in the URT-330 scores on treatment with the immunization versus standard of care in the patient with ESR1 mutation, you can see all these treatment differences are generally favoring the immunization arm versus the standard of care. Next slide. Important thing regarding the injection site reaction, you can see most patients, nearly 72% receiving the fulvestrant reported some sort of injection site reaction at any time, and around 47% experienced these reactions during the time on treatment with fulvestrant, which was not there with the immunization arm because that is the oral drug. Next slide. So again, overall change from baseline for the quality of life and the functional domains, again, you can see it was generally maintained across all the treatment groups. Next slide. Similarly, symptom domains were broadly similar across all the treatment arms as far as the which we call the overall symptom domain was concerned, except for the increased incidence of diarrhea, which I already told you in the abemaciclib arm, because we know that abemaciclib is likely to cause some sort of diarrhea. Next slide. So principally, this trial is principally done to show the efficacy of this drug and also to show that the quality of life remains better, almost stable or better with this combination. So the global health status and functional domains are maintained across all the treatment arms in this EMBER-3 trial. Notably, the patient outcomes were maintained with immunization plus abemaciclib despite the increased incidence of patient-related diarrhea. And both the longitudinal and time to deterioration analysis of this quality of life index numerically favored immunization versus standard of care in patients with ESR1 mutation. That was, as I told you, the PFS was slightly better, 5.6 versus 3.8, suggesting that this molecule delays the deterioration of quality of life without meaningful increase in the toxicity. So importance of injection site reaction as a clinical relevant AE for patient is demonstrated by the high incidence of patient-reported ISR with fulvestrant. So this trial showed showed that it is consistent with the primary results of EMBER-3 study. These patient-related outcomes reinforce the benefit of this molecule as monotherapy or in combination with abemaciclib as an all-oral targeted therapy option after progression on endocrine therapy for patients with this ER-positive HER2 negative advanced breast cancer. Next slide.
Thank you so much, Dr. Devender. I think this is another difficult to treat population where the patients come back very soon. And this drug also holds a promise. I think in the interest of time, we'll have to move on. Anshika, could you introduce the next speaker and we move on?
Okay, sir. So, for our next talk, I would like to invite Dr. Abhishek Anand, sir. He is a senior consultant and HOD in the Department of Medical Oncology at Paras Health, Patna, and he's going to speak on Destiny Breast 09. Over to you, sir.
Very good evening to all of you, and thank you, organizers. Thank you, Ashok sir, for this opportunity. So I'll be speaking on one of the abstract that was presented at the ESCO 2025 annual meeting, and it is of interim analysis or the interim results of Destiny Breast 09. This is trastuzumab deruxtecan plus pertuzumab versus taxane along with trastuzumab and pertuzumab for the first line treatment of patients with HER2 positive advanced or metastatic breast cancer patients. So this is the study design. It was a randomized multi-center open label phase 3 study for patients who were HER2 positive advanced or metastatic breast cancer. Asymptomatic and inactive brain metastasis patients were allowed for the enrollment, and disease-free interval of more than 6 months from the last chemotherapy or HER2 targeted therapy in the neoadjuvant or adjuvant setting were also taken. Randomization was done 1:1:1. There were 3 arms: TDXD along with placebo, TDXD with pertuzumab, and the standard arm that was THP, trastuzumab, pertuzumab along with the taxane. Primary endpoint being the progression-free survival along with the BICR. Key secondary endpoint being the overall survival. And at this time of planned interim analysis, where the data cutoff was at on 26th of February 2025, results are reported for the TDXD plus pertuzumab and the THP arm. This is the statistical analysis methods. Coming directly to the primary endpoint, which was the progression-free survival. If you see here, the BICR PFS, the median PFS was 40.7 months in the TDXD along with pertuzumab arm and 26.9 months in the THP arm. If you see the results at the 24 months, that is the end of 2 year, it was 70% for TDXD plus P arm and 52.1% in the THP arm. So the difference in the median PFS was 13.8 months, and this is the first line setting of HER2 positive advanced breast cancer patients. If we talk about the investigator assessment PFS, the median PFS here was 40.7 months in the TDXD plus P arm, and it was 20.7 months in the THP arm. Again, if you see the median difference between the TDXDP plus, versus the THP arm, it was 20 months. So this is quite huge difference when we consider first line therapy of metastatic breast cancer patients. For a long time period, for quite a long time, THP has been the standard of care. So subgroup analysis, all the subgroup favored the TDSD plus pertuzumab as compared to the THP, and the PFS benefit with the TDSD plus P versus THP was consistently observed across the pre-specified subgroup, including the stratification factors as well. The confirmed overall response rate for the TDSD plus P arm was 85.1%, with 15.1% of the patients having a complete response. In the THP arm, it was 78.6%, with a complete response of 8.5 months. Another important thing here is that the median duration of response. Here for the TDXD arm, it was 39.2 months, and for the THP, it was 26.4 months. So the response rates were greater with the TDXD plus P as compared to the THP and were durable as well. Although at the time of this analysis, overall survival was at 16% maturity only. However, the early OS data did suggest a positive trend favoring the TDSD plus pertuzumab over the THP arm. PFS2 was also longer for patients who were enrolled in the TDSD plus P arm as compared to the THP. And you can see here clinical meaningful improvement in the PFS2 with the TDSD plus P as compared to the THP arm. Overall safety wise, if you see the number of patients who had treatment discontinuation were only 20% in the TDXD arm, whereas in the THP arm it was 28.3%. Those associated with any dose interruption, it was 68.8% in the TDSD plus P arm and 49% only in the THP arm. And associated with the dose reduction, it was 45.9% in the TDSD arm and it was 19.9% in the THP arm. So safety wise also TDSD plus P was slightly better as compared to the THP arm. To conclude, TDXD plus P demonstrated a statistically significant and clinically meaningful PFS benefit by blinded independent committee review team versus the THP arm, which have been the standard of care for a long time. And it also consistently was observed across all the subgroups. Median duration of response of more than 3 years was seen with the TDXD plus P with a complete response of 15.1%. Median PFS was 40.7 months for the TDXD plus P as compared to 26.9 months for the THP arm. And the early data suggest a positive trend favoring the TDXD plus P arm with a supportive hazard ratio of 0.60 for the PFS2 as well. So the TDXD plus P demonstrated a statistically significant and clinically meaningful PFS benefit versus the THP arm and may represent a new first-line standard of care for patients with HER2 positive advanced or metastatic breast cancer patients. Thank you.
Thank you, Dr. Abhishek. Very interesting. So we are moving away from the classical chemotherapy, though TDXT also has a component to it, but the classical chemo to a virtually an antibody based or an ADC plus antibody based treatment. That's very interesting. And one obviously will have to wait for the OS data as well, but the PFS is very impressive. Have they reported the pneumonitis and ejection fraction issues in this abstract? No.
No, sir. In
Mhm.
the abstract, they have not reported, sir.
Thank you so much. I think that's Anshika, Abhishek. I'm sure there'll be a lot of discussion on this, and let me see if there is a question in the chat box. Somebody's asked Dr. Narendra Gemawat, effectiveness of HPV. I think that's a totally different topic from today's discussion. Anyway, if we get time, we'll come back to that. Anshika, let's proceed.
Okay, sir. So, for our next talk, I would like to invite Dr. Aditya Sareen, sir. He is an associate consultant in the Department of Medical Oncology at Sir Ganga Ram City Hospital, New Delhi, and he's going to speak on Asian 04. Over to you, sir.
Yeah, अब एसोसिएट हटा दो, अब कंसल्टेंट कर दो, अब हो गया प्रमोशन.
Okay,
Anyways,
sir.
thank you, Vatsar, for having me over here. And obviously, I'll be talking upon the.
Congratulations, Aditya.
Thank you, sir. Thank you. All your blessings, sir.
Always.
And we'll be diving into the discussion. Obviously, Vatsar likes to keep everything, spick and span as per the time as well. So I will not be going ahead with the further discussion. So straight away coming back to the topic, Ascent 04, again, a very interesting trial where we are seeing more and more use of, targeted therapy and immunotherapy in the upfront setting. So here we have a trial, which was a triple negative breast cancer, locally advanced, unresectable, with a PDL1 positive score CPS of more than 10. And so these patients were randomized into 1:1 with the secituzumab govitecan along with pembro, again vis-a-vis chemo plus pembro, which is the conventional, and this is what we are practicing in our day-to-day life. So their primary endpoint being where the PFS, and let's see what it showed us. So you can just see the PFS curve where you are achieving at 6 months the response PFS of 80% versus 60%, and at the end of the day at 72%, 10% benefit, and again at 12 months 12%, 12-month PFS rate is to the tunes of 15%. So now you see our conventional teaching of giving chemo with immuno is getting challenged over here in this trial with the hazards of 0.65. That means that there is a 35 reduction in the risk of disease progression or death if we are giving targeted therapy with chemo, and it is shown to be better in the terms of the PFS. And the same was proved by the BICR, and again they also came to the same conclusion. And if we were to go into the subgroup analysis, you can just see over here. Let me just take out my pointer. I think, anyways, so you can just see this de novo categorization. Yeah. So you can see here, yeah, this one de novo, it's not working that much, but in patients who has had, recurrence after 12 months, they have shown a significant hazards of 0.52, and it has worked in approximately all the age group and good ECOG status. And along with that, if patient has not received any prior neoadjuvant therapy, the hazards are fantastic over there, and obviously that contributed the majority of the patients. And chemo here was gem and carbo, which was used in a few of the patients as compared to the taxane. So you can just drive yourself that which chemos were used and how the patient has responded. Now, let me just erase it. Yes. Okay. So now the OS, the story changes in OS because the patients who were on chemo pembro were given secituzumab as the second line. So that's why there is a crossover, and OS data is still yet immature. But then again, if we are looking at a metastatic disease with that kind of PFS, keeping my chemo safe for the second line, I'm happy to take this data into corroboration once it gets the DO approval. And coming on to the tumor response rate, you can see a CR of 13% versus 8%. So then again, 5% more benefit, and a PR more or less same, and a stable disease more or less same, with the time to response being only 2 months. And the overall response rates, the duration of response, you can see to the tunes of 16.5 months to only 9.2 months. So you have a substantially longer duration of response and a higher ORR as observed for SG along with Pembro versus chemo Pembro. And the treatment profile, I think both the side effects were same. I think with the dermatological manifestations were a little bit higher in this arm. I think the data is yet to come. And with this, I think most of the things are really the same, which we all know. So to conclude, this trial supports the use of SG along with Pembro as a potential new standard of care in previously untreated PDL1 positive, locally advanced, unresectable, or metastatic TNBC. So OS is yet immature, but I think it is showing a trend in the improvement. So thank you. Back to organizers.
Thank you, Aditya. That was a wonderful presentation, breezy but very impactful. And again, we are talking of in a TNBC moving away from the traditional chemotherapy.
Yes, absolutely.
And, ADC and an antibody-based treatment. I think the paradigm is moving very fast, and
Yeah.
in the next couple of years, we would be practicing oncology in a very different manner.
AI based oncology ho jayega, sir.
Thank you so much, Aditya.
Okay, sir.
And I think we have come to the end of the presentations.
Yes, sir.
Ankita, yes, you can invite the moderator and let the moderator invite the panelists.
Panelist.
Thank you.
Okay, so for our panel discussion, I would like to invite Dr. Akhil Kapoor, sir. He's professor in the Department of Medical Oncology at Tata Memorial Hospital, Varanasi. And our panel discussion will be on what's new in MBC from bench to bedside. Also, because of poor connection, Dr. Javed Muzammil, sir, will not be able to join us for the panel discussion. So, Dr. Sheena Goyal and Dr. Ankur Varshney, sir, will be joining. Over to you, Akhil Kapoor, sir.
Akhil, we know we are behind schedule, but you don't have the pressure to finish within the, you have all your 40 minutes. Has Akhil joined? I
Sir, I
don't,
think he has left. He's not in the webinar.
did he join?
1 minute, sir. Let me.
I don't see him.
Okay. Uh, so he has an issue. So he had joined earlier, but he just left the webinar. So we are trying to connect with him again. So my
Just a minute, just a minute. Can Aditya, are you there? Aditya is also left. Any volunteers to take on the panel discussion? We can put the questions can be projected there and so other panelists have joined. Who all have joined?
Dr. Ankur Purnia sir has joined. Dr. Tanmoy sir has also joined, and Dr. Ankur Varshney sir and Sheena Gul ma'am is also there.
So there, and I can see Dr. Prashant also still there. Dr.
Yes,
Prashant, are
sir.
you there? No. So let's. What do we do then?
I have his slides if
I don't know. Now nobody's seen these questions and
Sir, I
anybody.
will take it. I will take the.
Excellent, excellent. That's a great proposition. Let's go ahead, Ankur. Let's go ahead. So
okay.
you are our champion. Thank you so much.
1 minute, sir.
No
I'll
problem.
just share the slides.
Share करो slides. ठीक है.
Recording in progress. Recording stopped.
Move to the next. So no. Move to the next slide. Anshika, move to the next slide.
Forward.
Next. Yes. Move to the next. I think the questions are. Oh, no, no, no.
Yes, sir. Questions are in between, basically related to all these
Okay, now
abstracts which were discussed.
let's go ahead. Ankur, let's go ahead.
So regarding this first study which was discussed regarding the Serena study, use of surge and changing based on ESR1 mutation. So it's a good concept. Two studies have now shown that we change the AI to a surge when the patient starts developing ESR good for a long period of time. So yes, we have the option now. Two drugs, though they are not available to us. So, but we have to identify whether how to implement this in the real world practice. So I'll start. These are the basic questions which will what are the barriers in actually into identify actually those patients to do a ESR1 testing. So any of the panelists can take the question. Dr. Tanma.
Okay, so yes, hi, I am Dr. Tanmay. So, what we see that the main barrier while when testing is the most important barrier, ESR1, we generally commonly, at least till now, even also we were not testing routinely for all these patients of uh, hormone positive, HER2 negative breast cancer for ESR1. Up till a few days or even now also, what we test is mostly the PIK3CA testing. Also, we do it, but yes, now this is one of the arena and as the days goes on, most of the labs have incorporated in their setting the ESR1 testing, but it's not available so floridly in all the labs. But that's one barrier what we see.
Yeah, totally agree because it's not commonly available, so it's not able to do for all those patients. We are
Right.
doing PIK3 testing. We started doing the testing as soon as we got the drug. So maybe when we get these drugs, it will push us to do more and more ESR
Right,
testing.
right. That's one issue.
So
And next, I
so
think we can go on with the question. So, what proportion of patients develops ESR1 mutation at progression? See, so actually, if you ask in the real world as of now, still the testing is not that much commonly done. So we don't have a real world idea about what is the amount or what is the proportion of patients who progress. But what we see that most of the patients who progress early, they tend to be a ESR1 mutant mostly. That is what is our feeling at present. But yes, if you ask about the proportion, it's around 10 to 20% of the patients what I feel. But yes, if you ask me real world, I don't have any data for that as of now.
yeah, totally agree. We don't have any hours data. Studies have shown varying from 20 to 40% developing ESR1 mutation when the patient progresses. So, so any of the other panelists can take this question whether regular, ctDNA, do you feel is a feasible strategy, particularly for patients of Indian profile?
Yeah, Dr. Ankur, Dr. Shaina here. So, I think the biggest challenge with doing the regular ctDNA testing is the financial toxicity that would be there because it is to be done as per the study every 2 to 3 months. And if you look at these patients were means they actually received the AI plus CDK4 treatment for almost a median duration was 23 months before they ultimately went into the randomization. So, doing these tests for every 2 to 3 months, for how long we don't know. If it's like almost around 1.5 years, that would mean very high cost. And obviously, the Guardant, which is the presently approved test with this study, we know the cost is quite high. So I think right now this won't be a very feasible strategy in our setting.
I totally agree. Financial burden is the first thing which comes to in each and every patient in our setting. So doing a test every 2 months to asymptomatic patients will be difficult to explain to them. So maybe, for a patient who is responding, broadening, and maybe doing after 6 months might be one of the things which can be done, though we can't be we won't be doing Guardant on each and every patient. Maybe our, home generated
Yeah,
test might be the way to go eventually. So
right.
next slide. So this was already discussed regarding this uh, Serena study, second study, which has shown basically that switching to a SERD based on ESR mutation has prolonged the PFS for these patients. Next slide. Next. So how do you feel really about what do you feel about you interpret the result of this trial?
So see, the results are good. That is right. But the real world setting, how will it impact? That we are yet to see in the real world, because we have seen that many trials which came, but in the real world setting, they change in in our Indian conditions at least, because most of the trials are conducted in the West, and we don't have a proper Asian population also in that. So, seeing these trials translate into a real world evidence is much more important.
I totally agree that actually whatever we see, we have to eventually implement in our day-to-day practice. So it will take some time. Eventually, things happen. Tests will become cheaper, and we get more and more access. But this is the way to go in the future. That we identify early patients who are going to progress. So we are even giving them a better outcome, a prolonged outcome for these patients. Challenges, all the second challenges which I feel are regarding the ctDNA testing, as rightly pointed by Dr. Sheena. ctDNA testing is not standardized at all, bar some few very expensive tests which are not in reach of majority of the patients. So more and more, what I feel is ctDNA is used, and more it will be standardized. The more accessible it will become to do this kind of test on regular basis. So next slide. So now coming to the second trial, an interesting trial of the second PIK3 inhibitor post alpelisib, which showed a overall survival benefit. So next slide. Next slide. Next slide. So sort of a hypothetical question. Previous slide, please. So patient is a PIK3 positive, HER2 low at metastatic diagnosis. How would you treat that patient? Whether you will target the PIK3 mutation first, you will treat with TDXT, combine, or do something altogether. Uh,
So, okay, so I think if we take our basic thought process that if anyone has a targeted mutation which is positive, then we need to target that first. That is what is our learning from the days of lung cancer and everything what we know. So I think I will be targeting the PIK3 mutation first, followed by its resistance. Then we go for the TDXT next line in as it's a case of HER2 low. That is what is the gut feeling also, and that is what we do. But one thing with the PIK3CA alpelisib, which is available at present, is it's a very toxic drug, very difficult drug to handle. That's the most important point which we feel with that.
I totally agree. Dr. Ankur, you have any other?
Hi, Dr. Ankur. And I would like to share one experience with regarding to this case. So I had a case of HER2 positive metastatic breast cancer. It started as per the Cleopatra regime. Patient did very well for 3 years, then had a disease progression, and we started on HER2. She did very well for 1.5 years, and then she developed progression. And post progression, we detected when we offered this patient NGS, we detected this patient was having a PIK3CA mutation. So I guess that NHER2 is not a very much excited drug to be used in PIK3CA mutation. And post PIK3CA mutation detection, we did offer this patient a combination of alpelisib with trastuzumab and capecitabine, and patient tolerated that fairly well, attained partial response on them. And as the concept goes on, if target is present, I would like to target first.
Yeah,
Because
totally agree.
if this
Yes,
was
please.
HER2 new 3 plus, then I was pretty much excited to use an HER2 upfront. But in a HER2 low, I will like to use the first line, which is approved, then only use TDX in the later line.
Yeah, totally agree. When we have a target and we can give a less toxic therapy and a better therapy, why not give that to the patient and
Yes.
reserve the ADCs and NR2 for the next line of treatment for such kind of patients? Maybe just for HER2 positive, I don't know. But yes, for a hormone positive with a PIK3 mutation, definitely a PIK3 inhibitor first,
Pick 3
followed by
first and then followed by HER2.
TDXT. So there was some discussion regarding that, whether patient, who progresses on first line treatment and then is very much symptomatic for the disease, would in such patient would you still consider, a PIK3 first, or would you think about giving like a TDXT to get a faster response, or you still believe that PIK3 will be a good enough option for them?
It depends on the overall clinical scenario. If this is having a symptomatic disease, I would like to treat with the chemotherapy first. If there is a chemo mutation,
Yeah.
because in
So
this setting, HER2 is okay, ठीक है, positive है, but low है. This is not classical HER2 new positive that we will get a very good response.
so you will prefer to give chemotherapy over an R2 for such patients.
If patient is quite symptomatic.
Okay. So we are going to discuss this trial eventually, Destiny, which is the
Yeah.
same thing more or less for chemo naive patients.
Yes.
So next slide. Next slide. Next slide, please. We have discussed all this has been discussed in the talks. So what do you feel that is triple therapy is the way to go, or we still should think about sequencing the drugs, whether those, how do we do this? Dr. Sheena?
Yeah, Dr. Shaina, actually. So,
Sorry.
this, I think, for a fit patient, as shown in the study also by Dr. Ankur, and what we know, PIK3 mutations won't really do well with using only the AI and CDK4. So I think a young fit patient upfront, we get to know a PIK3 inhibitor. I would be okay to use this regimen, triplet therapy, rather than do the sequential. And older patient where I feel the toxicity is difficult, as we know, the management of hyperglycemia is always challenging. I think I would go in for a sequential therapy.
Yeah, agree. So till we have, I think whatever new drug comes, we have to adjust to whatever toxicities there are and understand the toxicities, and eventually might be able to use in more and more number of patients. To firstly gain confidence, we need to do in a patient who, relatively fit to tolerate these drugs. But majority of patients which we are going to see are maybe 60 plus. So we have to choose the patient's ideal patient to start the therapy and eventually see how they do. So any other panelist has any other opinion regarding this, regarding using upfront triplet or doing a sequential therapy? Tanmay?
I think I would also go for sequential therapy there for an after therapy, after triplet.
So you're still not convinced with this?
No, no. Still, it's very early days. I feel that upfront or better is go for sequential.
I agree. Maybe when we drug comes, when we'll use it, maybe we'll gain more experience and we'll understand more about the drug. So next slide. So now regarding this Ember study, interesting study, combining SERD with CDK4/6. So next
Sorry
slide.
to sorry to interject here. We have 190 live attendees at this point in time on this program. That shows how well we are doing. Thank you so much.
Great, sir. So yeah, next slide. So we know that eventually we are going to get these drugs. Multiple SERDs are in development. Two drugs I think are approved. So eventually we are going to get a lot of SERDs here. So now we are assuming that we are going to, I think within this year, the next year, we'll get one of the SERD. So what do you prefer? You think about you prefer to use in first line therapy, or what do you think about using SERD irrespective of ESR mutations for these patients? So Dr. Shaina.
I would, I think, follow the first line therapies from as per the present guidelines, use an AI plus CDK4/6 inhibitor. And then if an ESR1 mutation is detected, then I would go in for the oral SERDs, if available, obviously. I don't think we still are using a SERD in the upfront setting, except if you want to use fulvestrant plus the CDK4/6 inhibitor. But as of now, my practice is AI plus that, or using a GnRH agonist, depending on the menopausal status of the patient. And would you consider using a SERD irrespective of the ESR mutation? Not really. Only I would keep it for the next line once this patient has developed at progression. If that time, if it's not ESR1 mutated, then I could consider using a SERD, but keep it for the next second line.
I totally agree. We don't have any evidence in the first line that using a SERD is more beneficial over other AIs or other drugs, and it has been seen in all the studies. Patient who doesn't have a ESR mutation does well, irrespective of whether they receive a SERD or AI or anything. So that might not be the one way to go. I don't remember one of the SERD. I think the first line drug trial was stopped early because of futility, because it didn't show any benefit in using in a frontline setting SERD compared to AI. So I totally agree. They are more like a replacement for fulvestrant till now, till we get more evidence. Further trials have started in the first line. Let's see what the future holds for the SERDs in the first line setting as well. Till that, I also personally feel it's more like a replacement for fulvestrant rather than a entirely replacing other AI or other class of hormonal agents. So next slide. So now coming to Destiny Breast 6 study and HER2, which is sort of the talk of the town for breast cancer disease, which have sort of changed the outcomes, particularly in HER2, uh, and bring the ADCs to the forefront. So this has already been discussed. Uh, it has shown benefit regarding all those mutations. It didn't make any difference for NR2. Uh, so yeah, next slide. So now again, I'll ask the question again. Earlier it was the same question. So whether if a patient presents with ESR1 mutation and is HER2 ultra low, how do you decide to treat the patient? Dr. Ankur?
So if we go with the trial design, they have taken patient post hormone therapy, post 2 lines at least. So I
Yes.
don't see that if a patient come to me with upfront is such a profile, then I will be bold enough to use TDX as a upfront first line therapy.
So as coming to the second part of this question, whether a patient had a PIK3 mutation as well. So what would you do for a patient? All these three kind of things are there. You have all the targets, all the drugs. How would you like to treat the patient?
So definitely, if such a patient come to me, he is not a candidate for endocrine therapy. And whether this I will add PIK3CA agent with endocrine therapy, this will be a dilemma for me. But in this condition, I don't think the very first choice will be a TDX for me. With ESR1 mutation, with PIK3CA mutation, with HER2 ultra low, upfront setting, not in upfront setting. In post 1 or 2 lines, definitely I will use an HER2.
Yeah, I agree, more or less the same thing. If patient, have also progressed on multiple
I
lines,
think,
so 1 or 2.
yeah, I think for now, only a PIK3 mutation in the first line setting, we can think of using PIK3 inhibitors. Other than that, having an ESR1 or a HER2 ultra low, we don't change our plan of treatment of using a standard of care, which is a CDK4/6 with endocrine therapy.
I totally agree. In first line, we will not change.
We are not
Standard is
choosing based on any of this.
yes, we are going to give upfront, basically hormonal agent along with CDK4/6 or other SERDs or PIK3 inhibitor. So this is basically for patients
Probably
who
in a
progress.
second line, if this is there, if this patient has progressed on an AI and a CDK4/6 and has an HER2 ultra low with an ESR1 mutation, would we prefer to use a SERD, oral SERD plus means either a CDK4/6 continuation versus TDXT and HER2?
So let's say as we don't have access to SERDs, so if your patient develops a ESR mutation, what will you do for that patient post first line setting?
Yeah, I think that would be an interesting discussion for now. Whether what do we do for a second line? At this point, what we are doing is starting if a patient has a PIK3, then fulvestrant plus try for an alpelisib. If the patient is not having a controlled diabetes, or exemestane as the older drugs we go back to. Otherwise, TDXT can be an option for this patient in second line.
Yeah, agree regarding that. So,
Sir, anything from your side?
Ashok sir, you have any opinion regarding this?
No, I broadly agree with the observations. And because the ESR1 can be modulated, you still have fulvestrant as one of the choices for ESR1. PIK3, you have no other choice than to use PIK3 inhibitors, whether it is alpelisib or any one of the other drugs. And in the again, the analogy is you have a target, you treat the target first, and then go decide about the HER2 ultra low, which can be the subsequent line of therapy.
I totally agree, sir. So we try to prolong the patient to not go on chemotherapy or chemotherapy-like drugs and give the targets and hormonal therapy to the best the point as possible.
Absolutely.
So, next slide. So now coming to this Destiny Breast 09 study. Again, an interesting study, sort of changing the standard of care for HER2. So and HER2 is sort of changing in all the settings, standard of care for all kind of breast cancer, not just HER2, even hormone positive. So yeah, next slide. This was already discussed, first line setting, comparing, we have a single arm TDXT plus P versus THB. Next slide. Next slide. Next slide. So let's say now we have this option with us that, so what to do for a patient, a new patient which comes to us who is HER2 positive, tomorrow it comes to us, HER2 positive metastatic breast cancer patient, how we like to sequence the drug for these patients? So Dr. Tanmoy, Dr. Ankur.
So this is very interesting and very tempting data, but I think full paper is still not published.
Yes.
So before jumping on it, I will like to assess the full paper first.
So still you would prefer to give THP to the patient.
And the overall
When full
survival,
paper is there, FDA approval is there, then definitely I will go for this thing.
and
But
also the overall survival data.
yeah, also overall survival data.
EFS is compelling.
PFS is compelling and the difference is also very compelling. But I will like to wait for full paper and FDA approval before making it in my practice.
Yeah, we have to look at the paper. We have to look at all the nuances, what happened regarding all the toxicity and other metrics
And
as
I
well.
am still doubtful why, because so much interesting data is there and they are discussing abstract everywhere. Why the full paper is still not in NEJM till now?
And we have still not heard about the cardiac toxicity and the pulmonary toxicity.
Maybe those things are stopping it from getting published in NAGM.
Yes.
They're not providing the proper data to their reviewers there. Maybe one of the cause, but still, I will say very interesting. More, very highly likely, I will say, will change the practice and a standard of care in the future. Looking at all the other trials, what Enhertu had done in all other settings. So very
Yes.
likely what I feel. And also that single agent arm will also tell us how the individual, single agent TDXV also does against the THP, whether it does as well as the combination or as better than THP. We also need to do that because we have to look at the financial toxicity as discussed. Again, giving multiple drugs, multiple expensive drug is not feasible for majority of patients.
Yes.
So I agree. We need a longer, at least paper should be there to look at all the nuances of the trial. And ultimately, a golden thing is we need to do a overall survival data, but that will, I think, will take a long
Look at the
period of time.
EFS survival curves. Look at that. The median is still not reached. So the patients are going to be on treatment for a long, long period of time. And they would be consuming a lot of drug. They are 24 months, 70% versus 52%. And I think we'll have to wait for the more mature data and the toxicity data as well.
Yes, agree, sir. At least toxicity data, but I feel I need to little bit analyze what kind of toxicities happen to these patients to decide for my next patient whether I'm going to tell them that Enhertu is yes one of the first line option for them.
Absolutely.
So this already discussed. So in any patient subgroup, do you feel that this might be best to start with this drug? Any particular subgroup which you feel, Dr. Shaina?
No, I think what Dr. Vetsar and Dr. Ankur has already discussed, we still need the final paper and more data to take it in the first line, and it's not yet approved. So I would still go for the standard of care first line. And as per the optimal sequencing, Petina for triple positive and PDXT in second line.
Yeah, agree. So any subgroup where you feel that patina, regarding that patina, that any subgroup which you feel that you might not, you have to give chemotherapy upfront, or you like to give just, um, hormone therapy, a triple positive breast cancer patient, yes,
No,
hormone therapy.
after chemotherapy only. I would like to go for that. For HER2
So,
positive patients, start with the anti-HER2 and chemo, and then put them with the addition of a CDK4/6 along with the AI.
yeah, agree. That has been the standard of care for a long, long time. Though personally, I started to believe, and I'm starting to believe for some time, that we can spare majority of those patients who are triple positive with chemotherapy upfront, and most of the patient does well with chemotherapy and hormone therapy combination. So that's just my opinion, but yes, majority of data shows that we have to give chemotherapy upfront. So next slide. So coming to the last study, which was discussed, again, an interesting study in a space where we don't have that many of options. Ascent study. Next slide. Next slide. Next slide. Next slide. Next slide. So is Dr. Tanmoy here?
Yes, yes.
So what do you feel regarding this study? And are you convinced regarding that use that yes, we start using this combination and upfront setting for this little bit, population of one of the population worst doing population of all kind of breast cancer patients?
So see, it's a very new combination which we see. Real world, no evidence. I would still be waiting for further results to come before using this one.
I agree. A little bit early data. We need a little bit longer follow-up. We don't have access to this drug, and I also agree. I don't have any experience of using the drug or this combination. We just now had a combination of combining ADC with pembrolizumab in another setting, but for this particular breast cancer patients, we don't have the access to this drug. Majority of us and don't have that much experience. So for patient who have received pembrolizumab in early setting, would you still think that we can might re-challenge those patients again when they develop metastasis with this such kind of combination when we start use? Or as such only without this combination, would you think of re-challenging those patients? Dr. Ankur?
If I go by current scenario, then if PDL1 is more than 10%, I would have used PDL with chemotherapy, immunotherapy with chemotherapy in the very first setting. So
No, so,
after,
no, so basically for patient who have used early breast cancer, so if
uh,
patient develops the
no, if
metastatic, then
in the later lines, post 1 year of gap.
so you think 1 year gap is adequate to
Yeah,
re-challenge?
yeah.
Yeah, I agree that more the bigger the gap, more likely the patient is going to respond again, rather than patient who progresses within few months after giving the therapy is unlikely to respond to immunotherapy, because for patient who has a response to immunotherapy tends to do for a good number of months. So unlikely to work. I totally agree. For patients who does progresses within 6 to 8 months is a small period for immunotherapy per se to re-challenge again. So anybody has any experience with the use of sakituzumab?
So we have used in triple negative and later lines, not upfront. And obviously, this is a very very expensive drug, and combination with pembro is unthinkable at this point in time. And but
So
we haven't had very durable responses with SG. Maybe they were used in the third, fourth line setting, but no experience in the early lines. No.
yes, sir, the magnitude of benefit is very very small as such in the later line settings. It's
Absolutely.
sakituzumab. So any particular toxicity, which unique toxicity you saw with any?
Not really. That way the drug didn't surprise us, and probably we have used in 3 patients. It didn't surprise us. Went on well. The tolerance was good. The biochemical parameters stayed good, and no organ specific toxicities we encountered. But that's a very small number, you know.
Yeah, agree, sir. So what do you feel about this study, sir, regarding using upfront a combination of this?
So again, it's a very early days, and in a subset of patients, more than 10%. Again, the financial toxicity, more data is required, longer follow-up. I think we need to learn a lot more about this combination. Again, see the ADCs and the immune checkpoint inhibitors, IOs, are going to change the scenario. They are going to blow away everything. You know. Now, the only point is that how long is the data? How robust is the data? And toxicities, now we are very familiar with them, with each one of them. The cost, durability of the responses, I think they will be very, very important from the Indian standpoint.
Yes, sir, agree that cost is the first thing which comes to mind, and majority of the patients will not be able to take the drug because of the cost, and very few, I say, highly selected patients will be able to take it, because patient who responds will have to take probably for a long period of time, and it will become financially more and more burden on that patient the more longer the patient has to take as well. So
True,
not good for a patient even who responds to take this drug, you know. So
true,
yes,
because
but
then it becomes a dilemma. You know, someone who responds cannot afford it. What does he do? You know, and then somebody who doesn't respond has already wasted a lot of money in the process. So it's a dilemma for both of them.
yeah, totally agree, sir. That's why, that's why there's the art of oncology, and we're learning more and more about it. We'll get some biomarkers. Eventually, we start using the drugs, and further drugs. We'll get some biomarkers to better identify the patients who are more likely to respond. It's not a perfect science, but yes, we might be able to better identify those patients. And
Thank you
so,
so much, Ankur. I think we now the number has gone up, 202 live attendees. Thank you so
great,
much,
sir.
Ankur. First and foremost, I have to thank you for taking up the panel discussion and doing it so enthusiastically, so involved. I think very special thanks to you. And thanks to
Thank you, sir.
AstraZeneca for putting up this program. And thanks to all the presenters, Dr. Shaina, Dr. Ankur, Dr. Devinder, Dr. Prashant, Dr. Abhishek, and Dr. Aditya Sareen. And the other panelists, Dr. Tanmay, and of course, Shaina, and again, Ankur, again, stepping into the panel discussion. And thanks to Mice Ideas for the technical support, for putting this together, for all the communications, getting the slides up there. And we hope to come back again with something more innovative and more educational. Thank you so much. Take care. Good night. If anybody has a last comment, please, you could step in. You know, Tanmay, he's everybody is now. Ankur, if you have something to say, thank you so much.
So nothing to say, sir. We are getting more and more drugs, and I think one of the most exciting field is oncology, and breast cancer field is becoming more and more excited in the coming future.
Thank you. Thank you so much, Dr. Srishti. I can see you on the program. Thanks very much. And for your support and your enthusiasm and your belief that this program would be good for everyone. And indeed, at the end of it, we're all very excited and much better informed. Thank you so
Thank
much.
you, sir. Thank you, sir, for all your support and guidance. Thank you.
See you.
Thank you, sir.
Bye-bye. Thank you.